Good evening. Welcome to AIG. And yet again, we are conducting weekly eminent international speaker program. And every week we invite international speaker to discuss with us about the pandemic which we are living through, the COVID, and how it is affecting our life. And as a gastroenterologist, how we are affected. So today we have eminent speaker from Germany, and we'll be discussing with him about how they are coping up with this pandemic and how they have changed their endoscopy practice during this epidemic. I'll introduce the speaker. He is Dr. Torsten Beyna, and he is head of the Department of Gastroenterology and Endoscopy at Evangelica Hospital, Dusseldorf, Germany. He is a very well-known figure in endoscopy circuit, and he is upcoming gastroenterologist all over the world. We also are fortunate to be joined by Dr. Govind Makharia. He is very well known in India and abroad also. He is professor of gastroenterology at All Indian Institute of Medical Science. He is also Secretary General of Indian Society of Gastroenterology. And I have with me Dr. Sandeep Laktakia, who is a very senior gastroenterologist, as we all know him. He is also Secretary of SGI, the Society of GI Endoscopy of India. So let's start, and we'll invite Dr. Torsten Beyna to deliver his talk, and subsequently we'll have discussion on this, and we'll invite questions from the viewers. Thank you very much. And please, Torsten, you can start your lecture, please.
Hello. First of all, good afternoon, and thank you very much for this very kind invitation to let me participate in this very successful series of webinars on the current topic of the pandemic. So I'm going to share my slides now with you so that you can see. I hope this will work.
Yes, we got it.
Can you see my slides now?
Yeah.
Yes.
Yeah. So once again, first of all, best regards to my my very dear friends in India. So thank you. I would like to take the chance. So thank you for this wonderful collaboration and friendship. So thanks for having me. My topic is now the current SARS coronavirus outbreak and the special situation that we have in Germany. This will be topics of my presentation. First, some words about the background, then what do we know about the pandemic, about the virus, and then I would like to go to this very special situation in Germany. Why do we have such a low death rate in Germany? What measures do we apply to the community? And then in the special part will be how we maintain our endoscopy service during this pandemic, how we schedule patients, and some words about personal protection, hygiene, and endoscope reprocessing. Something about the background. We know in late December 2019, the first patients were presenting with viral pneumonia due to an unidentified microbial agent in Wuhan in China. And then we have the identification of the novel coronavirus as a causative pathogen. In beginning of January, we had the confirmation of the first human-to-human transmissions, and then we had the genomic characterization of the novel coronavirus using next-generation sequencing of samples from bronchoalveolar lavage in January, in the beginning of January. The first reports on a real-time PCR test were available in January 23 by the group of Christian Josten, who is the head of the Department of Virology and Epidemiology in the Charité University in Berlin. And after that, the first cases of the pandemic of the COVID-19 disease spread over Europe till mid of February. Very few cases, only 47 cases have been reported. but then the pandemic started to speed up. So we were very lucky that at the beginning of February, we were able to let our international endoscopy symposium take place together with a very known international faculty. So we are, I think we were the last ones that were able to let these large events take place. Very successful, more than 2,000 participants from over 55 countries. But even during these days, the discussion already started. We didn't have any guests from China at this point, and after that, almost every major event was postponed or even cancelled. About the background, currently we have a little bit more worldwide than 4 million confirmed cases. These are the numbers provided by the Johns Hopkins University in US. And as we know, recently we had some very good publications in the New England Journal, and so in the beginning of March there was this work that compared the SARS coronavirus 1 and 2 and its behavior in aerosols or on surfaces, and they found in this bench testing there were no differences between both viruses. So the different epidemiologic characteristics probably arise from other factors, and we know now that these factors are that we have a very high viral load in the upper respiratory tract. We have the potential of virus shedding and infections from also from asymptomatic patients, and this opens the potential for nosocomial spread and also some super spreading events, like we know some events that occurred in Germany and in Austria. So we know there were some super spreading events. Interesting is what we now know about the virus and the outbreak. Currently, we know the sequence of the virus. It's available in GenBank, and since we have a real-time PCR test available since January, we know globally a little bit more than 4 million confirmed cases are there. We know that the new coronavirus 2 causes the COVID-19 disease, a disease that can be severe and difficult to manage. We know that the pandemic has the potential to kill millions of people worldwide. We know now that we don't have any causative treatment or immunization currently, and we know from China that very drastic control measures as implemented in China were able to mitigate the spread of COVID-19. We also know that we have usually a transmission that is done by respiratory droplets, but we also know that we have other contact routes with direct contact to infected people or indirect contact over surfaces. Airborne transmission of the virus is not proven, but in analogy to what we know from SARS coronavirus 1 and from the Middle East respiratory syndrome, it's very probable that airborne transmission compared to droplet-based transmission is possible. The potential of a fecal oral transmission is not proven yet. So this is what we know, but there are some things we know that we don't know, and these maybe are also very important. We don't know the exact number of infected people, what means we don't know the documented cases plus the undocumented cases, and we don't know the exact number of deaths that were caused by COVID-19 disease compared to the ones deaths that occurs with SARS coronavirus 2 as only a bystander. We don't know the exact infection fatality rate, that what would mean the number of deaths from a disease divided by the total number of cases. What we don't know. What we know is we have the confirmed fatality ratio. That means the number of deaths from a disease divided by the number of the confirmed cases. That we know, but is probably a very high impact of undocumented infections on the virus dissemination and statistics. So going to the situation in Germany, Why is Germany an exception? Even the New York Times and some other major media were talking about this. So maybe there are some reasons. The death rate is relatively low in Germany. Is it why does this occur? Is it probably there are some reasons for this. So if you have the statistics, you can see the confirmed case fatality ratio is very low in Germany, 4.1% compared to other countries around the world. Belgium has by far the highest, but Germany is very low. And if you look at the mortality, death per 100,000 population, Germany is again very low. Maybe the statistics in Iran and Brazil will change during the next weeks. So why is it like this? Are there explanations? So on the one hand, there may be some statistical distortions. We have seen that the average age of infected patients in Germany seems to be lower than in other countries, compared 50 years compared to 63 or 62 in France or Italy. And we do a lot of tests. We are testing far more people than most other nations, what means we detect more people with few or no symptoms. That lowers the death rate, at least on the paper. In terms of testing, we were very lucky that the real-time PCR test was very early available in Germany because it was developed by Christian Josten and his team. So we started in early January, and we applied very early in widespread testing. Currently, we are doing more than 500,000 tests per week in a population of 82 million. We do regular tests for medical staff, and all tests are free or at least covered by the public insurance. This finally leads to a very early diagnosis and the potential of isolation, early identification, and treatment of the severe cases. We are then following some tracing strategies to avoid contact to confirmed cases, and we have a relatively robust public healthcare system. We have 28,000 intensive care beds in January 2020, what means a number of 34 per 100,000 people. That's relatively high compared to other European countries, 12 in Italy, 7 in the Netherlands. And we were able to increase the number of ICU beds up to 40,000 intensive care beds in April 2020. We started relatively early with social distancing measures, and there was a relatively high trust in the government, and the restrictions that were met with only little political opposition and are broadly followed, at least during the last 8 weeks. So this person you probably don't know, but in Germany is now very famous because it's Christian Josten, and he and some other experts in virology and epidemiology give advice to the government. Christian Josten is the head of the Charité University, the Institute of Virology in Berlin, in Germany. In history, he was the first to identify the SARS coronavirus outbreak in 2003 and introduced the first real-time PCR test. And during this pandemic, he was the first to report on a test, a real-time PCR test for the SARS coronavirus 2. He and his group. So he's also very efficient in making scientific data transparent, not only to the government, but also to the population. So everybody is very glad that we have him, and he and his team lead us through this crisis. So it's very helpful. Yeah, what measures were taken in Germany in March 22? We started with public health and social measures in Germany. We closed borders to almost to most of the neighboring countries. There was no strict order to stay at home, but to follow very strict social distancing measures, what meant that there was a ban on public gatherings of more than 2 people, except families and so on. We closed schools, kindergartens, shops, restaurants, and as per request by the government, we had to suspend elective surgical procedures and interventions since March 13. Why did we do it like this? So we had this model analysis, what meant if we would not apply any measures during these days, we would expect about 70 million infected people till summer this year, and that would mean that there would be a need for intensive care treatment for about 500,000 people at the same time. And this would be far more than the 22 or even the 40,000 ICU beds that were available in Germany. So another model was calculating with moderate measures, still a lower number, but the curve has been flattened, but still need for 200,000 intensive care treatment beds at the same time. So then the government decided to apply very restrictive measures that would expect 450,000 people infected at the same time and a need for intensive care treatment of about 24,000 people at the same time. So this would be something that is possible to be covered by our healthcare system. The drawback, on the other hand, is if you flatten the curve like this, you have to continue these restrictive measures for quite a long time, maybe at least 1 year or even longer. And what was the effect? As you can see at the beginning in March, we had up to or even more than 6,000 confirmed new cases per day. And this went down. And now we are at less than 500 new cases, confirmed cases per day by the beginning of March. And the reproduction number, what means the number of people that are infected by one infected person, went down from over 4 to less than 1. And this was the goal that was planned to be achieved. So currently the situation in Germany is luckily very stable. So the infection numbers are going down, and currently, starting 2 days ago, we are relaxing the measures step by step. So in the first round, we opened again shops, of course, car stores. In Germany, you have to open the car stores to make the people happy. But then schools, stepwise opening schools, and we are allowed to reschedule patients also for elective procedures since May 6th. Other relevant changes were not made. There was still a ban for major events until at least end of August. But the plan is to further increase testing. We are introducing tracing apps to follow confirmed cases and to know who is in contact to who. How long do we have to continue these measures? So in Germany, we had about 170,000 documented infections right now. There are some population-based trials not confirmed yet, but they suggest, the results suggest that we have a very high number of undocumented cases of about 3.3 million at the moment. But to achieve a herd immunity would need at least 55 million people having been infected of a population of 82 million, and this would take quite a long time. So if you can see the light at the end of the tunnel, what meant we achieve a herd immunity. We achieved 6%. So maybe this is not the right way to go. So we have to wait for vaccine, for immunization, for the pandemic to as an escape out of this pandemic. The current situation in Germany, I already mentioned this, is quite stable. We have still free ICU capacity of more than 12,000 beds. As you can see, in Dusseldorf, it's a relatively small city of 600,000 people living here. We have only 13 confirmed cases at the moment. 9 are ventilated on ICU, but still capacity of more than 100 ICU. So we are lucky to relax the measures and to go for endoscopic procedures, to reschedule endoscopic procedures that have been postponed. But we still have to take care of reducing the risk of transmission in the hospital. Of course, we follow standard precautions, but we apply additional precautions that are directed to the transmission of the virus, to avoid contact and to avoid droplet and airborne precautions. Currently, the recommendation by the German Center of Disease Control, what is the Robert Koch Institute, is if in the hospital we can happen that the healthcare provider has an unprotected contact to a proven COVID case, then as long as the person is not symptomatic, he can still continue to work with a surgical mask to protect others from the droplets. So this strategy helps us to prevent a lack of staff and healthcare providers. So currently the situation is stable. Inpatient settings we use single rooms for possible and confirmed cases. We have dedicated cohort areas for the confirmed cases, and we use close monitoring of the confirmed cases as they are risk candidates for intermediate care and ICU treatment. For outpatients and visitors, we use a triage system. Everybody has to undergo a triage and risk stratification before entering the hospital, and there are very strict regulations for transferring the patients, operations of surgical and endoscopy theaters, and especially for the environmental decontamination. How do we schedule our patients for endoscopy? So currently we still do the triage and risk assessment of patients for COVID-19. Every confirmed or suspected case confirmed with positive real-time PCR and suspected with acute respiratory illness without any other etiology or recent contact to a probable or confirmed case are considered to be high-risk cases. And in this situation, indication for endoscopy is still limited to emergency and essential cases, as this was also documented in the recent Asian Pacific guideline published in GUT a couple of weeks ago. Emergency procedures for these patients are ongoing bleeding, foreign bodies, obstructing GI lesions, acute hepatobiliary cases like obstruction, cholangitis, and so on. Every procedure that is needed for urgent nutrition support, and every endoscopic management of perforation or leakage. So as we are still in a stable situation, we can reschedule urgent procedures, but still on a case-by-case discussion. Usually the procedures that are needed for the diagnosis and staging of GI neoplasias. Of course, endoscopic resection of early GI neoplasias, endoscopy for occult GI bleeding, ERCP, EOS cases for the management of hepatobiliary neoplasias, endoscopic procedures that are needed for the management of dysphagia, like POEM procedures, for example, or diverticulotomy, and also colonoscopy cases with new suspected non-infectious colitis. And as you have heard before, we are now allowed to even reschedule elective procedures. This also includes screening colonoscopies and every kind of procedures. We are currently about 85 to 90% of our usual workload. When you schedule the patients for endoscopy, currently we have to consider the national regulations and the trends in of new cases of the COVID-19 disease that are reported in Germany on a daily basis. And we tell our patients, if we schedule them for a procedure, it could happen that we have to postpone the procedure even on the morning of the intervention, but the patients are very happy that we are now going to treat them, and they understand this, and so it gets more and more normal. So we have to consider local factors like available human resources, the resources of personal protection equipment. During the last weeks, it has become better, but before that, we even in Germany we had to face a shortage of personal protection, especially masks. Yeah, but now the situation has improved. The availability of endoscopes, other equipments, the beds in the hospital, ICU capacity, and also patient factors, the risk assessment for COVID-19 disease, and the impact of the endoscopy of the overall clinical outcome. So in the beginning of March, we started to postpone elective procedures or procedures that are not considered to be urgent, but we have to think about that it will take a very long time to achieve herd immunization of the entire population, and still there's a long way to go to get a vaccine for the COVID-19 disease. So in every patient, we have to weigh the risk of COVID-19 transmission in the hospital and the problem of lack of resources against the impact on deferring procedures to the patient's clinical outcome. For patients for the patient in between, we arrange telemedicine and also virtual visits for the patients in the waiting time to avoid direct contact to the patients. So I will switch now a little bit to what we're doing in the endoscopy unit itself. So we know that the SARS coronavirus 2 is an envelope virus, what means cleaning and disinfection should be easy. We don't have to change anything. We can use our commonly used products and protocols. We can use neutral detergents that are effective in attacking the virus lipid membrane, and we can use disinfectants with virucidal activity to inactivate the SARS coronavirus. In terms of endoscope reprocessing, it's the recommendation by the ESGE is also the same. We should follow the standardized and validated reprocessing cycles. We should do this very carefully to have a very thorough bedside cleaning, then transport the endoscope in a closed box, and this should be marked as a contaminated endoscope to your cleaning facility. And then it's important to apply immediate manual cleaning underwater surface to prevent droplets on the surrounding surface. And then the virus can be easily inactivated in the automatic reprocessing in the wash and disinfect. You should avoid manual reprocessing cycles. You should not reuse cleaning equipment like brushes, and keep in mind the decontamination of surfaces in the procedure and in the reprocessing room, and to give also personal protection equipment to the ones that take care of decontamination of your rooms. So what can we do to protect the staff and the team? Distance and hygiene, it's very important for the team. Use distance whenever possible. During the procedures, we have only essential staff in the rooms. This affects also training of our fellows, but currently this is not possible to do this very extensively. In the beginning, we tried to divide in different groups and shift. We don't do that anymore because there was no need. And in the endoscopy unit, we use limited furniture and equipment in the room. We try to avoid sharing phones, pens, computer workstations, and medical equipment. And very important is the hand hygiene. We always try to avoid touch the face mask and glasses. It's some change in our behavior, but it's possible. As a personal protection equipment, we have on the one hand low risk patients and high risk patients. What mean high risk of infection or the confirmed cases. For the low risk patients, we use surgical masks. And very important is the protective eyewear to use or disposable face shields like this. And for the high risk and confirmed cases, you need respiratory PPE like FFP2 or 3 masks. These masks correspond to the N95 or N99 masks in the US. So as a final slide, I would say that protection of the staff should have priority. So during the first weeks, we had to face a shortage of personal protection equipment. We were not sure if it would be possible to have prolonged use of these masks, but it's very important that we have very clear instructions by the team leaders and the experts when to use surgical masks, when to use FFP2 or 3 masks. Very important is to protect your mask. Use face shields to protect the mask, not only yourself, but also to protect your eyes. Think of decontamination of these shields. And very important is communication. The team needs daily updates on your recommendations, standard operating procedures, and about the current availability of material and staff. And this is end of my presentation. I thank you all for your kind attention, and I hope we can have a nice discussion during the next minutes.
Thank you, Torsten. It was fantastic lecture.
Thank you.
Govind, you have any comments from your side? I got Indian perspective.
Absolutely. It's a fantastic talk, Dr. Beyna. It's a wonderful talk. And we all have been wondering why Germany has low mortality. And that's very encouraging that Germany had low mortality. And we believe that in India also we have till now almost 70,000 cases, confirmed cases, and mortality has been about 3%. Mm-hmm. And we wonder why it is so that why mortality is low in this country too. There are a couple of reasons of that. One of the reasons you already said in your talk that the population of elderly people in any country, for example, in most European countries and even in the United States, almost 15 to 20% of the whole population belongs to more than 60 years of age or even 65 years of age. India, unfortunately, I would say that we have that population only 6%. We have more of young people. And it's going to change with time. Our average lifespan in 1950s were just 40 years. Now it is almost 70 years now, which is increasing with time. Certainly over time, we also will have a large population of elderly people, but at this point of time, we have a low number of elderly people. So that was one of the reasons of having low mortality in our country. We also expect with time, as we go, we have not yet reached the peak of the epidemic. Once we reach the peak of the epidemic, probably in month of June or July, then we will know that what mortality we have. Certain number of cases are going to increase in our country, in India, and but mortality probably will remain to be limited. That's a very good point about COVID in India. And wonderful preparations by Germany, the kind of preparation you did were so remarkable. And this is a kind of education for the whole world, that how do you prevent mortality in your population once a pandemic of this kind you have to face. Thank you so much for your wonderful talk. Yes. And
Thank
we'll
you.
take, we'll take some questions. Yeah. We take some questions, Sandeep.
Yeah, so I think one important thing which Germany did compared to rest of the world was early testing, aggressive testing, and they had the luxury of the RT-PCR getting available to them by their own person who invented that. I think they had that advantage, and that aggressive testing made a huge difference, I think. But still 6% of the total population only infected now. We'll probably know how things happen with passage of time, and that's what we are also fearing in India. That fear still remains, how things will change with time once the current lockdown in India gets little eased down step by step. I think it's more important, probably what I feel is that if the younger people get exposed, who are hale and hearty, they will probably be a carrier, then quickly they'll improve the herd immunity. Rather than the elderlies who are more predisposed to serious illness. That's my point of view. I think the younger people, if they get exposed quicker and faster, then the herd immunity base would increase.
But during these days, the younger people in Germany become more and more nervous. So we are relaxing measures at this moment, and that means during the first weeks, everybody followed the restrictions and the measures. But you cannot keep these measures for a month or half a year. This will not be possible, maybe. And so, yeah, I don't know what you think, but maybe we have to bring the younger people out to get immunized and and then to keep the country running. This is what a lot of people think.
Only thing that if the younger person gets exposed or he gets the virus and he doesn't have symptoms, he should not carry it home to his elderly people at home. So those who have vulnerable people at home, I think they should not venture out. But those who have no high-risk people at home or in their immediate surroundings, they can be more liberal in getting themselves exposed, if I can use that word, in a safe manner. Then probably the herd immunity will eventually make a difference. I don't know how long the vaccine is going to take. We keep hearing news very often that it's going to be 6 months away, 1 year away, 1.5 years away. Only time will tell which is the most effective vaccine. I know many candidate vaccines are undergoing trial in many parts of the world. Which one comes first and is most effective, only time can tell. So till that time, I think we have to expand the base of the herd immunity, so that if that would probably prevent the explosion which could have happened.
Okay, so that was about the epidemiology. But we'll discuss more. Torsten is here. He is heading a unit in gastroenterology. So we'll ask him about how you restarted your unit. So what are the measures? You already spoken in your lecture that there is a method of triage, and then you let the patients in. Do you do testing also before keeping the patient on the list, which are non-emergent or non-urgent cases? Do you do the testing, or is anybody doing in the Europe where the mortality is high?
Yes, we don't test every patient that enters the hospital, so we don't do that. But I know that in some countries this is done like this, and even some hospitals in Germany do it like this. So in the beginning there was a shortage on available tests, but now as we have enough testing capabilities, and we have tests. We have the results in less than 1 hour. We're going to test more and more of the people. And what's probably also a problem is that after we finish our treatment and the patients have to go home or to go to a nursing home or something like this. These are, at least in Germany, the ones that are at a very high risk. So maybe we have to test the patients 2 times. One first time when entering the hospital, and then that they are then allowed to leave the hospital to go away. So, but currently we in our unit don't test every patient. The symptomatic patients, yes, but and the ones that have a history with potential contact, but currently we don't test every patient.
And what is your protocol about testing healthcare in your hospital, healthcare worker? Because the patient can transmit to the healthcare worker, but healthcare worker also can transmit. So you spoke about healthcare worker in your unit being tested. So what is the protocol?
Yeah, so we only test the ones that are symptomatic, but everybody in the hospital wears a surgical mask. So as a standard protection, everybody's wearing these masks. So this is what we're doing. Then we everybody who had contact to a high-risk case or a confirmed case is going to be tested, and then the ones that are symptomatic also get a very short test, and we have the results in less than 1 hour. But there's no testing of the entire staff, if you mean.
Okay, so it's based on only on symptoms.
Only on symptomatic
patients. That is, of course, a risk, as we know that also asymptomatic patients can transmit. But yeah, this is what we're doing currently.
Another interesting point which you made was about the healthcare worker being tested twice, the patient being tested twice. So these are the patients who were inpatients or those who came for endoscopy?
Inpatient. As you know, the system in Germany is a little bit different, so we don't do that much therapeutic endoscopy in outpatient setting. So usually we have for interventional procedures, we have inpatient settings, and then if the patient goes back to a nursing home, something like this, we know we had some major outbreaks in Germany in these nursing homes with more than 50% of the elder people dying in these nursing homes once the virus came into it. So this is why we need to test before bringing the patients back there. This is the reason.
Govind, you have some questions?
Two or three important points we want to learn from Dr. Beyna. One, that you have a center, which is Advanced Endoscopy Center, and you must be getting a lot of trainees coming from different parts of the world as a part of short fellowships, 3 months, 6 months. And this time, all those people have come for fellowship. 3 months, maybe 3 more months will go. So do you want to compensate by extending their fellowship duration, or have you thought about it? Because this question comes to us that during training in our GI fellowship, we believe that at least 6 months will be last where you can do any kind of active interventions. So is certainly going to affect the training programs. So what are your thoughts about that?
Yeah, that's correct. That's difficult. So in the beginning, we were not allowed to accept any person from outside to visit our endoscopy unit, as we do not offer hands-on training or at all. So we don't have this special situations to have people for 6 months or longer. But the ones that wanted to come to our unit during the last 2 months, so we postponed their visits. So they will arrive end of this year or beginning of next year. Yeah, that's correct. We were not allowed to accept anybody from outside.
Very true. And one more point I think I want your opinion on, that we know that this virus, SARS-CoV-2, is a RNA virus. And till now, the vaccine against RNA has been really well challenged. We have been trying the Hep C vaccine for almost 10 years, and we don't have any success of that. So a lot of people are, while they're hopeful, this wonderful thing to hope for, that we have vaccine for SARS virus in coming maybe 1 year down the line. But also there are people who believe that it may not be possible at all, because this virus changes its structure very frequently. So do you have any thoughts on that?
This is what I fear most, that despite all these efforts and the billions of dollars that are spent on developing this vaccine, will not finally not succeed. But yeah, so some groups that were do the research were very confident. So this is why I'm also confident. But it could. It's the only way to go. So.
Absolutely, the only way to go. Absolutely, yeah.
But yeah, maybe it will not come in this year.
Less likely to come this year.
A lot of people are waiting for it, but maybe not this year. And then it will depend on how the virus will behave in the future, how fast these changes will occur, and if they have a large impact on the immunization. Maybe it's a annual vaccination, like for influenza virus, as we're doing in Germany before every season. But yeah, I'm not yet convinced.
Absolutely. One more practical question, if time permits.
You wrap up.
Mohan. That's the like use of a PPE in endoscopy. So I'm not talking about those patients who are confirmed COVID, but those patients come for routine. Say you have a list of say 5 patients today for endoscopy to be done in these 5 patients having cholangitis or GI bleed. So do you change the personal equipments every time, or you do all 5 together by limited staff?
So we change after the personal protection. We change after every procedure. Okay. So we.
So there's no risk. Yes.
If you protect your own mask, then you can keep the mask. Maybe that was the thing that was very difficult to have in also in Germany during the last weeks. But yeah, after that we change, and then we. The room is cleaned in between using standard disinfectants, and then yeah, it takes a little bit longer than usual, but this is why we do the triage before. And if the patient didn't have any contact or confirmed case or is symptomatic, then yeah. But this is more a practical approach.
What am I asking? If we have a low risk patients coming for endoscopy, yeah. Even when you change your whole equipment every time, even for low risk people.
Yes, yeah. Despite the face mask. Yeah.
True. Okay.
I think before we wrap up, I'll just ask one more question, Torsten, from you. How difficult are you finding it to do procedures, those high-end procedures endoscopically, wearing all these PPE? Do you get fogging or headache, or the bridges of the nose get abraded? How challenging are they in your practice?
You have to drink a lot during the day because you lose a lot of fluid. Yeah, it's a different kind of breathing if you have the face mask. You have to get adapted to this. Luckily, there was no need to perform longer ESDs or something like this with a FFP2 mask, but this would be really a challenge. Yes. Yeah, but usually you get adapted to this. Sometimes for me it's a problem when I have the during ERCP procedures, if you have the radiation protection on the glasses, and then the face masks and the face shield and the radiation protection. So this can be a long day, but
then you can't see the ERCP film. It's difficult to see the screen then sometimes when so many layers in front of the eyes. Even if they're transparent, it becomes difficult to see that fine things on X-ray.
Sometimes the view becomes a little bit foggy then.
Yeah.
Yes.
Very true.
Fogging is a big problem.
Yeah.
So we are just devising how to
We are
prevent
getting
this.
used to it gradually, but it takes time. I think with that we will wrap up this show.
Air conditioning.
Thank you very much, Torsten. Professor Torsten Beyna from Germany, Dusseldorf, and Professor Govind Makharia from All India Institute of Medical Sciences for sharing your experience and for the wonderful talk. Thank you, Mohan, for coordinating the session. We wind up here from Asian Institute of Gastroenterology, AIG Hospitals, Hyderabad, for this lovely session. Thank you very much.
Thank you, sir. Bye-bye.